Oh, okay. All right, looking around, we have about 11 minus a couple of us. We'll give it another minute or so, but thank you all for joining us. We'll do introductions in just a moment. If you know of any colleagues that you think we're missing, let us know. I'll give it to like 9:03 to be prompt. And we'll keep letting people in. So we go. Oh, here's one more person. All right, 9:03, let's get started. We'll keep letting people in as they join us, but good morning. Thank you for joining us. Today we are talking about understanding and confronting commercial sexual exploitation of children. This presentation is a collaborative partnership between Mission Kids Child Advocacy Center and the Children's Hospital of Philadelphia, or CHOP. Your presenters today. My name is Michelle McDyer. I am the Director of Prevention, Education, and Outreach at Mission Kids Child Advocacy Center. For those of you who might be unfamiliar, Mission Kids is Montgomery County's Child Advocacy Center. Montgomery County, we are the third largest, most densely populated county in Pennsylvania. So we serve a wide variety of children across our county. We're located right outside of Philadelphia. But we provide direct intervention services for children whenever there's an allegation, suspicion, or disclosure of child abuse. And we provide forensic interviews so that the child can speak openly and freely about what has happened to them. And then we also provide family advocacy services. So that includes mental health referrals as well as medical referrals. And we have a really great partnership with CHOP where children can get intervention services from renowned physicians in this field. So we're really proud of that partnership. And part of what I do is prevention education. So speaking to kids as young as 4 years old, we speak to teenagers, and then we also do presentations for adults. So trying to put my adult hat on today because I'm excited to speak to some adults. But we do a lot of discipline-specific trainings, and this is one of them that we're really proud of. And my colleague is Hannah Cornell. I'm going to turn it over to her to introduce herself.
Morning, everyone. Like Michelle said, my name is Hannah Cornell. I am the External Affairs Manager at Mission Kids Child Advocacy Center. I came on to Mission Kids to oversee and manage a grant. And in that grant, we were developing and implementing a replicable response to both child and adult victims of sex trafficking. So I still work a lot with our CSEC response and initiatives, as well as really monitor and advocate for different legislation and public policy related to child abuse and neglect. So with that, I will throw it over to Anish.
So good morning, everybody. Thank you all so much for being here. So my name is Anish Raj. I'm one of the fellows in child abuse pediatrics here at the Children's Hospital of Philadelphia, or CHOP. I'm also one of the founding directors of the Adolescent Protection Collaborative, also known as the APC Clinic, which is CHOP's specialized medical home for sex trafficked youth that we launched just about a year ago, so in July of 2021. And we can certainly talk a little bit about that clinic and the kids that we have served. Thank you again for this opportunity.
Thank you. So we're very happy that Dr. Raj is joining us for this. Like we said, this is a discipline-specific training. We received a grant to train different disciplines across the state of Pennsylvania. So we are doing these presentations for law enforcement, child protective service workers, medical providers, and prosecutors. So we're doing these discipline-specific trainings We really do think it's important to get these trainings out to medical providers. We know that parents look to physicians, that children look to physicians as a safe person to learn from. So we know that this is really important to get this out across the state of Pennsylvania. So we really appreciate you joining us for this preview session. Today we're going to meet from 9 to 11, and then we left some time for feedback from all of you. And then the more extended version will be a 4-hour training with more situational scenarios, experiential activities to really do a deep dive into this topic. But we're really excited to share this with you. If at any time you have questions or feedback or anything, you can use the chat function. I should mention we also have Sarah Marino, who is one of our community prevention educators. So she's going to help us with the chat box. And then we also have our CEO, Abby Newman, here. She is an attorney and a nurse. So she has both the medical malpractice field, a lot of expertise in this area. And I know it's a passion of hers. So she is here today as well. So they can help us too if you have any questions. But before we get started, wanted to make sure that we are creating a safe space for all participants. Some of the content that we're going to cover throughout this presentation may be upsetting or disturbing to some participants. We know that you all are in this work every day. You're in this helping field, but some of these topics might affect you differently. So we just want to make sure that you are practicing your self-care. If at any time you need to turn your video off, get up and stretch, get a glass of water. I don't know where you're at in Pennsylvania, but in Montgomery County, it's a beautiful day. It's like 84 degrees today. Get some fresh air. Make sure that you are practicing that self-care today. And again, we do appreciate you committing your time and energy to this training today. And we know that the ripple effect is going to be huge. We're going to help a lot more people with this training. We want to get started just letting or seeing who's in the room. So if you can just let us know in the chat box, what is your job title? How many years have you been in the field? Just curious to see who's in the room. Edward, welcome. Colleen, Pennsylvania Department of Health, Division of School Health. Awesome. Thank you for joining us. Congratulations on your retirement. Child abuse pediatrician, speaking the same language as Dr. Raj. Annette, thank you so much. Thanks for the work that you do. Oh, good. Medical Director of York and Adams CAC. So you know our friends in Adams County and York County. It's great. Reading, PA, sexual abuse evaluations for Berks County CAC. Great. Teresa, also shout out to Teresa for helping organize this. Thank you so much. Awesome. So I'm glad to see that some of you are already working with the Child Advocacy Center or you're working in the pediatrician field. So hopefully some of this information will be familiar to you, but I hope that you do feel empowered hearing what information we're putting out there for other people who might not be as well versed in this field, because this really is a shared responsibility of every adult, especially people in the medical field where people are getting their information and services from. So briefly, our learning objectives today, 5 major points of what we want to talk about. We're briefly going to go over definitions and laws, just making sure that we're using the same definitions of sex trafficking and commercial sexual exploitation of children, which we will probably be referring to as CSEC throughout the training. We will go over the federal and Pennsylvania state laws, but by no means is this going to be a law lecture. Don't walk away yet. We're not going to bore you with that. We will talk about victimization and identification. So examining those vulnerabilities and risk factors that make a child susceptible to CSEC. We'll go over the red flags and indicators that you might see when working with patients. We will briefly touch on perpetrators. So understanding the methods and recruitment and conditioning that are used by exploiters and traffickers. Next, we'll talk about trauma and ways to engage with victims, especially as they experience complex trauma, what that might look like in a medical setting, and then the process. So we're going to talk about appropriate steps to take if you suspect CSEC, what resources are available, and Anish is going to talk about some of the work that he's doing, some cutting edge stuff in this area. So we're excited to share that part. Agenda, that's what it looks like for today. 1, 2, 3, 4, 5. We'll try to make it as efficient as possible and make sure that you're getting the most out of your time here today. So first, we're going to hand it over to Anish to talk about a case.
Sure. So folks, before we dive into the nitty-gritty content, we always like to start these with a little bit of a mental exercise just to gauge where we're all starting from and also just self-assess where we might have our own kind of tunnel vision. So what I'm going to do is I'm going to present a couple case vignettes, and all I ask is, I recognize that it's early, so I'm not going to be calling on people. So if everyone can just sit back, look at the images, read the case vignettes, and just reflect on the initial thoughts or images that pop into your head when you see these. So first, we have a 3-year-old little kiddo being evaluated in the child abuse clinic for a question of sexual abuse perpetrated by her 13-year-old stepbrother. Patient is briefly interviewed, responds yes when queried if the alleged perpetrator scares her, and then she further states, quote, "I don't want to lay down with him." Now, I recognize that I know about your fields and how long you've been working. Since we're all pediatric providers, I don't want to assume, but I do imagine that this is the kid that kind of tugs at our heartstrings, right? This is a kid that we empathize with, that we want to protect. We worry about her safety. We worry about the exposures and environments that she is in. And this is the kid that, I think to the T across the board, we want to help and we want to figure out how we can support. I want to do this one more time. So if Michelle, if we can flip on the other vignette. Now we have a 15-year-old who presents to the emergency department, brought in by law enforcement, who's acutely intoxicated after being found in the back of a vehicle with an unknown adult male. This patient is noted to be, quote, crying and screaming, refuses to engage. And then I know this is being recorded, so I'm not going to curse, but she says, "I'm going through my own stuff." She declines all offered services. Now, for those of you that have been working in pediatrics, especially throughout, for the duration of your careers, this kid is not asking for help in the traditional way. She's not presenting to the hospital, asking for something. It's a little bit harder to engage with her. As you guys can probably imagine, her emergency department triage note likely uses the word aggressive or mentions that she's aggressive. Her social work evaluation might say that she's not cooperating with the interview. Her inevitable psychiatric evaluation is probably going to mention trauma at some point, but that is likely going to be clouded within the context of her acute behavioral symptoms. But the reason we bring up these two vignettes, guys, is that this is actually the same kid. It's actually the same kid, just 12 years apart. And it's a girl that I had the pleasure of taking care of over the course of my career. And as you can imagine, in those 12 years, life wasn't entirely kind to her. She had a lot of experiences, a lot of exposures that wouldn't necessarily be obvious to us as clinicians when we're meeting her at that one snapshot at that one point. So we use these little vignettes just to remind us that, again, we never really know the full context. Even the most deft clinicians don't have all the history as to what's happening between clinical presentations. So with that, I do want to hand it back to Hannah, just that we can start with a little bit of a video and then jump into the content.
Thanks, Anish. So like Anish was saying, the stories, the vignettes are so important. And something that we do want to raise is just the voice of survivors here this morning. Elevating the voices of those with lived experience is so important. They are the experts of their experience. They are the experts in this topic. And so this video we're about to play, it's from thelifestory.org. It is an incredible resource. And so this video is really going to capture the voices of those with lived experience.
I grew up in a household of violence.
It's the story. I mean, it is the story of foster girls that I know.
The brown and blacks they're throwaways. A lot of the kids are throwaways.
And then we found some guy on Craigslist that said he was doing swimsuit modeling.
The goal was to get the money so I can get the apartment so I can get my son back.
I couldn't do those things that I would do with those men unless I was high. At that time period, there wasn't systems in place to give me the follow-up care and the services that I needed.
Thanks, Michelle. And so before we really jump into the base knowledge around this topic, we just want to highlight this invisibility of exploitation. So we do know that based on evidence and research, CSEC victims and sex trafficking victims are seeking medical care. Different studies have revealed that between like 80 and 88% of survivors report that they have been in contact with a healthcare provider. That is a huge percentage. That's an overwhelming majority say that they have sought healthcare services. However, on the contrary, only 6% of healthcare workers report treating a victim of CSEC or human trafficking in their entire career. And a lot of that can be linked back to just a general, perhaps lack of training. Some studies show that around 65% of medical providers report no previous history or experience completing a training on this topic. And so what we really want to highlight with this slide is that this is a huge opportunity. It's a huge intersection where we know survivors are seeking care. And so this is an incredible opportunity. And again, we're so happy for the opportunity to present to you today on these topics. So we are going to start off with some definitions and terms. We're going to clearly define what CSEC is, right? We've been using this acronym all throughout the presentation. And so what is CSEC? We want to ensure that we have this common and shared language as we move forward. And so CSEC is the commercial sexual exploitation of children. And what that is really a broad range of activities involving the sexual abuse or exploitation of a child in exchange for anything of value. And so CSEC is really this broad umbrella, and under that umbrella fall a couple of different things. So one of the biggest things here is child sex trafficking. And a lot of experts in the field use these terms totally synonymously, using CSEC and child sex trafficking interchangeably. But also under this large umbrella really falls the commercial production and distribution of child pornography, child sex tourism, and child marriage. But again, for the purpose of this presentation, we're really going to be using the term CSEC and child sex trafficking synonymously. So going back to that definition, right, we see that it's a sexual abuse or exploitation in exchange for something of value. And that something of value could be something that's so broad, right? It's not just money. Looking beyond that, we're seeing food, shelter, maybe it's drugs, access to substances or alcohol. Again, it's anything that that child perceives as being valuable. And so we're going to get into this on the next slide, but it does not include force, fraud, or coercion. There doesn't need to be a third party. There doesn't need to be a quote trafficker directing this child to engage in these acts. Something like survival sex, for instance. If the child is exchanging a sex act for the necessities to survive, like food, shelter, different things like that, there's no third party necessary. That child is a victim of CSEC or sex trafficking. And the focus and the onus really needs to be put on the person who is targeting a vulnerable youth and exploiting them. And so we can see here, this is the US federal law, the Trafficking Victims Protection Act, and this was passed in 2000. A really helpful way to remember this, at least for me, is the AMP model. So we can see here we have the acts, by a means for a purpose. And this is how our federal law defines sex trafficking. And we can see here on the screen, there's the big red X, right? So for adults, there is legally a need to prove a means, but for children, and I can't stress this enough, there is no need to prove that means. All that is required under the US law is an act for the purpose of commercial sexual exploitation. And you can see that list of acts there. Maybe somebody's recruiting them, enticing them. Maybe they're reaching out to them via Snapchat or Instagram. Maybe they're harboring them in an apartment, in a hotel, providing different things for them. Maybe they're providing them alcohol or a place to sleep or different things like that. But all that we need is that act for the purpose of commercial sexual exploitation. And so again, that anything of value, we have these pictures here up on the screen. And these are things that we see all the time in Montgomery County when we do this work. We see a lot of money exchange. Maybe it's via Venmo, via Cash App. Again, that place to sleep is so, so crucial. A lot of homeless or housing insecure youth are very, very much targeted. We can see, again, maybe it's food, maybe it's a meal from McDonald's, Chick-fil-A, you name it. And then you can see at the bottom here, maybe it's high priced or luxury items. Maybe it's a new purse, getting your nails done. But again, these are very tangible items, but in some cases, we've really seen something more intangible. We've seen kids who have exchanged sex acts for a sense of protection. Maybe there were threats against them or their family. Maybe it was a heavy gang-related activity. And so in order to stay safe, they were forced to exchange sex acts for a sense of safety. So I hope you know who this is on the screen. This is Liam Neeson from Taken. The movie Taken, gosh, it really has shaped our narrative and our understanding in many ways. And I don't want to assume for you all, but I know a lot of times when we go out and do trainings, people, when they see the term sex trafficking, they think, oh yeah, like Taken. So I feel like we've had to do so much work to talk about Taken and really thinking through how this has informed and sort of guided this narrative around what sex trafficking is. And so we like to start off busting some common misconceptions and myths. And it seems like the movie Taken really encapsulates all these myths, right? That somebody is being forcibly taken overseas, that it's a young white female, and that somebody is going to fly across the world and rescue them. But this is really, really not the case. So something that we like to start off saying is that sex trafficking is absolutely something that happens here. And I'm sure you're all very well aware of that. Just this past year at Mission Kids Child Advocacy Center, just in Montgomery County, just children, we identified and served 54 victims of sex trafficking or commercial sexual exploitation. So this is something that happens here in the US, and it's certainly something that happens with US residents or citizens. I know sometimes a lot of folks might think it's something that only happens at the border, that happens with foreign nationals. However, research shows us that about 85% of all victims in the US are permanent US citizens. And so moving to that next bullet point, traditionally there's a lot of discourse and a public narrative around trafficking victims solely identifying as female. However, data shows us that among children, it's about 70-30. So 70% of child victims identify as female and about 30% identify as male, according to some studies. And that's even on top of many of the young men that came forward in this study disclosing there was such a stigma around coming forward. There was such a reluctance to disclose because of the stigma around these issues. And so again, just broadening our understanding of what this is, what it looks like, who are the victims. And then to that last point, transportation versus intrafamilial. This is certainly something that doesn't require transportation. It's something that can happen to a child and they might never have left their home. So there absolutely doesn't need to be an element of transportation. And so moving on, here are a couple of recent case examples from Mission Kids. Again, like I said, Mission Kids served 54 suspected victims of CSEC in just 2021. And so, of course, these names and the details have been changed. These are recent kids that we have seen. So Olivia was given drugs by adult men in exchange for sex. Brian, he identifies as LGBTQIA+, and he was kicked out of the home. He has been surviving on the street by exchanging sex acts for food and shelter. Shania ran away from her foster home and meets up with older men she connects with on Snapchat who solicit her for sex acts. Nadine was sexually abused as a child by a family member and discloses that I was going to be assaulted again. I might as well make money off of it. Ashton's parents are deceased, and she has a history of running from placement. She has a prior history of sexual assault, but she's never identified her trafficker. And so again, these are based off of real cases that we've seen. And we place the slide right after Mythbusters, because if we really think around the public discourse and the narrative that we're seeing in the news, right? If you've heard about the Wayfair scandal and empty car seats in Walmart parking lots, right? This is such a strong dichotomy about in comparison to what we are seeing. And so just really highlighting what this looks like and how it is manifesting here in Montgomery County. So like Michelle said, we are going to very, very quickly go over the state law. This is by no means a law lecture, but we're going to start off by addressing Pennsylvania's first comprehensive anti-trafficking statute. This was passed in 2014. So that AMP model that we talked about, the federal law, the Trafficking Victims Protection Act, was passed in 2000. It actually took 14 years for Pennsylvania to get an anti-trafficking statute on the books. We're actually one of the last states to get this law on the books. And so what this law really did is it expanded our legal definition of human trafficking. It gave prosecutors the tools to hold perpetrators accountable and really provided enhanced protections and confidentiality for victims. So moving along, this is a little bit more recent. It is hard to believe, but prior to 2018, a child could be arrested and charged with the crime of prostitution. And just letting that sink in, because that is just so wild, that we have statutory rape statutes on the books, right? But if there was somehow this element, this commercial element, suddenly we were charging these children with a crime and treating them as criminals. However, thankfully, after much advocacy and much work, this safe harbor law was passed. And what this did is it ensured that children were treated as what they were, which is victims of a crime, victims of sex trafficking, who absolutely cannot be charged and prosecuted for prostitution and offenses related to their victimization. And so it really creates that dependency in lieu of delinquency. And the last law that we are going to briefly touch on is the CPSL. I'm sure you're all very familiar as mandated reporters. It was in 2016 that the law was updated. And so CSEC is now required that anytime there's a suspicion of CSEC, it's a mandated report. So we are going to talk about some risk factors in red flags. And so we can see here on this list, who is at risk, right? So if we look at this list, children who are at risk to be recruited into the life, recruited into sex trafficking, are children who are under 18, maybe they walk places alone to school, to the store, to friends' houses, they own or have access to social media, a computer. They like flashy consumer goods, want to have romantic relationships, maybe feel insecure, misunderstood, feel misunderstood by their parents, want to take risks. Looking at this list, who is at risk to be recruited into CSEC? The answer is most children, right? All children. If we look at that list, and if we feel really uncomfortable and, you know, put ourselves back in our shoes when we were, 14 or 15, you couldn't pay me enough money to go back there, right? But if we look at this list and think, gosh, that's most children, right? So most children, children who exist within our society are absolutely at risk, but we do certainly know there are children who are at a much higher risk. And so we're going to start off again by playing a story. Again, this is all from the perspective from the expertise and the experience of those who have been through the life and those who are victims and survivors of sex trafficking.
I was staying in a house where there was about 6 other kids staying. It was the basement of somebody's grandmother's house, and we were all living down there, and it was rat infested, and we all had scabies, and I mean, it was disgusting, but it was a place to live.
It was one day we were at the transit center and didn't really have anywhere to go, and that's kind of where everybody hung out at the time.
I was just kind of couch surfing, living where I could, staying where I could. And then one day
I was sitting at a bus stop with a friend, and a lady rolled up with a really nice car.
I was at the grocery store in the parking lot, and I met, there was a group of guys out there.
She was like, I would like to hang out with you guys if you guys want to hang out.
And they all had really nice cars, and they all had really nice jewelry.
They were like in this really fancy hotel with the hot tub in it.
It smelled really good and were good looking and all of that. One of the guys in particular came over to me and started talking to me, and he wanted to know where my family was. He wanted to know my situation. He wanted to know a lot about me. And in my mind, I was thinking it was because he was interested in me and he just wanted to know me as a person.
Kept ordering food and bottles and everything, and I was kind of like, where they kind of like explained like what she did and his part in it.
And he started slowly talking about prostitution.
I've never even heard of a prostitute before, and then that was the day that I actually finally met one.
You know, he had a nice car, he had money, he had clothes, he had all this stuff that I didn't have and that I wanted. I grew up in a really alcoholic home, a lot of violence, a lot of yelling, things being thrown, people being hit. It wasn't a happy place.
Me and my uncle got in a lot of fights, physical fights, and that's kind of when I started like veering towards the streets, because I never wanted to be home around my mom and my uncle because they were always so mean to me.
When I was 15, I got pregnant, and my father abandoned me. He told me to never come back, so I never went back. So I was on my own after that.
I didn't have any like rules. I could come and go as I pleased, so I could stay out for a couple days and come home and change, or I could stay out until 3, 4 in the morning and come home, sleep. I started stealing from stores, hanging out in abandoned buildings.
I didn't have any money, I didn't have any way to make money, and I didn't have anywhere to live with my child, so he went with his father's family. A lot of my friends' moms that were single would let me stay, but I had no permanent home.
There's people that are out there that are predators that target young people, that they know that they can target them because they need a place to stay or something to eat.
You know, I think I was so beat down and so just my self-esteem was so gone that at that point I think I accepted that this is what I was gonna do, and that this is what I was and this is what I was worth.
At the end of the year, when I was 11, we were sitting at the bus stop, and there was another girl there that was like crying and stuff. Well, she had just got kicked out of her place, and she didn't have anywhere to go. So we all kind of put our head together about like what needed to be done in order to get some money so that we can get a hotel room. That's when my friend that was with me when we met the girl at the hotel was like, well, I have an idea on what we can do, and all decided to go to Pack Highway and walk down the street and make some money. When I seen the girl do it, she said $100. She said $100. That's how much that they're supposed to pay. So when he asked me how much, I said $100, and he said okay. That was kind of how that started. That was the first time that I did that.
That video is so powerful, no matter how many times you've seen it, and there's always something new that jumps out. So when we do our extended training, when we do this 4-hour training, we really ask folks to dive in and talk about what commonalities they saw among the survivors. And a lot of folks say, you know, growing up in a household of violence, housing insecurity or instability, not having a lot of supervision or boundaries. And so that's something that in the longer version we would unpack and have a discussion around. But for the sake of time, we will keep moving on. And so looking at the different types of risk factors. Again, going back to that point that we talked about, right? All children are really at risk. And we can look at this outer circle and really think about society as a whole, and that children who exist and, you know, people who exist within our society are really at a risk due to a general lack of awareness about what this crime is. If we think about our culture, in the hypersexualization of children that we have, right? People are posting ads on different websites saying barely 18. There's absolutely a hypersexualization of children in our society, and the demand for commercial sex within our society is huge. There absolutely is people who are willing to purchase sex, especially in, you know, countries that have a high economy, that are, quote, developed economies, because there is this money, there is this influx of cash which people are willing to spend to purchase sex. And so again, there's just generally a lack of awareness and a huge demand, which really drives this crime. We can see at a community level, right? Maybe there's peer pressure, maybe within that community, there's a social norm. We've heard stories regarding when there's housing insecurity, in order to make ends meet and make rent, sometimes it's sort of a social norm within that neighborhood or within that community that selling sex acts or something like that is just something that you do to make ends meet, right? But this is absolutely an exploitive, unequal power dynamic as well. And so maybe it's communities where they're under-resourced, right? So we heard in that last example, just a general lack of resources, a general lack of eyes or support for these young women. Again, relationships, conflict, disruption, dysfunction. We heard the young women talk about how they grew up in a household of violence. They didn't want to be home at all because of the dysfunction on that relational level. And so then looking in and really honing in on these individual risk factors, again, it's not that, you know, a child needs to have all these things or one of these things, right? Because they have so many layers of different risk factors, societal, community, relational. But on this individual level, we see a history of child abuse, neglect, or maltreatment across the board, across research. This is proven that it's absolutely one of the biggest risk factors, and that between 70 and 90% of CSEC victims have a prior history of childhood abuse. Again, that's up to 90%. And so that's a huge, overwhelming majority of these kids. Homeless or runaway, right? That was literally the name of the last video we watched, right? Runaway. LGBTQIA+, certainly transgender youth are very much targeted, having a history of being systems involved. And I think I saw something pop up in the chat. Absolutely, substance abuse, the opioid epidemic is a huge, societal, community. I feel like it could be in all of these circles, right? And so thank you for pointing that out. That's a good addition. And so really highlighting that point that between 70 and 90% of CSEC victims have this prior history of childhood sexual abuse. Why is there such a strong interconnection and causality between these two things. And so if we look at the left-hand side, if a child experiences child sexual abuse at a young age, often in 75% of cases by somebody they know, love, and trust, maybe that child begins linking the concept of sex and abuse as being equal to love. This is what love is. And it really shapes their understanding of others, of the world, and of themselves. And maybe along with this experience, there's feelings of guilt and shame, viewing themselves as a sexual object, having low self-esteem. We heard the one woman in the video talk about, at one point, I thought this was all I was. This is all I was good for. This was all I was worth. And so these experiences really shaping our perception of self. And maybe that child, runs away from home. Maybe there's poverty. Maybe there's emotional needs that when a trafficker or an exploiter, a sex buyer comes in, they will work to meet that need, to maybe shower this child in love and affection, a romantic relationship, a parental relationship, a friend relationship. And then over time, slowly interspersing these feelings of love with sex and abuse. And so again, then this fits within the child's perception of self, the perception of the world, that love is equal to sex and abuse, the unequal power dynamics between these relationships. And so when they're approached by that person and this continues to happen, it really fits within in their purview of themselves and the world as well. And again, there's just such a strong link there. Many of the kids that we see at Mission Kids who have come in previously for allegations of child sexual abuse, unfortunately, many times when they come in for a new allegation of CSEC, unfortunately, in many cases, we've seen this child before. And so moving on and thinking through the stages of grooming, for traffickers, this is absolutely a business dynamic. Just like we are experts in our jobs, you're experts in the medical field. Many of you, it's your full-time job, right? For traffickers, many of them, it is their full-time job, it is their expertise, down to a science for them about how they are recruiting these children and grooming them into the life. And so they're targeting children with noticeable vulnerabilities, all of the risk factors and vulnerabilities that we talked about. They're working to actively gain trust, to build rapport, to discredit others in their life who they might know and trust, and really working to fill that need, whether it's emotional, physiological, you name it. They're identifying those needs and they're making over time that victim depend on them to have those needs met. The next step that we can see there is isolation, really isolating this child from any sort of supports, networks, or resources that they might rely on. And again, going back to making that victim, that child, fully dependent on them. And so maybe this abuse begins, and it's often interspersed between maybe a relationship of romance, of a parental figure, a friendship, and then slowly over time, this is how the trafficker maintains control. And Michelle is going to talk about trauma bonding and the complexity of these trauma bonds in a little bit. And so this was something that was actually taken from a book, which is available on Amazon. It's about how to be a pimp using Maslow's hierarchy of needs to make the most money. Unfortunately, this is something that's for sale on Amazon that literally outlines, like, here's how you do it. Here's how you maximize your profit. And again, thinking through, this is a multi-billion-dollar industry. And so what this pimp writes about is making sure to consistently meet their physiological needs: food, water, warmth, rest. And over time, when we consistently meet those physiological needs, it establishes this feeling of safety and security. And maybe for this child, it's the first time in their life they've had consistent access to these things. And so they're feeling safe and secure for the first time. And so over time, then meeting those love and belongingness needs, right? Establishing those intimate relationships. Moving on from there, meeting the esteem needs, right? Telling them they're so good at this. You're making me the most money. You're the best girl I have, et cetera, et cetera. And so really building them up and filling those esteem needs. which leads to the last point, which is self-actualization, achieving one's full potential. And the author of this book, this trafficker, writes that the goal is ultimately to convince these children that they are your business partner and that they should go out and recruit more children into the life. And so we can see how this continues to move on in a cyclical fashion. Recruitment locations, where is all of this happening? And the biggest point and the biggest takeaway here, it's anywhere that youth or vulnerable people are spending time. And the biggest call out here is social media. I would say that nearly every case that we've seen at Mission Kids has some sort of element of social media involved, whether that's Snapchat, Instagram, Facebook, you name it. There's some element of social media, especially given COVID and the quarantines. That's something that we've seen a huge significant increase in. Others on the list are, schools, transit centers, malls, youth centers, youth shelters is certainly a big one. So with that being said, I am going to throw it over to Nish to talk about considerations in medical settings.
Sure. Thank you, Hannah. So guys, we recognize that these are all very big picture concepts. So we'd like to switch gears just a little bit and bring this down to where most of us work, and that is in a clinical or medical setting. For those of you that have worked for decades in the field, you probably know that we're still in the early stages of literature around CSEC and trafficking. Again, for those of you that have worked in the field for 20, 30 years, there probably wasn't that much medical literature to guide our decision-making up until about 2010. Since 2010, there's been mostly a jump and an explosion in the literature, and yet we're still at the early stages. However, what we do know is that when it comes to the health issues for kids that are affected by CSEC or trafficking, they're at higher risk basically across the board. And so that includes, as we would imagine, by their innate involvement with the sex industry or their sex trade, higher rates of sexually transmitted infections, especially undiagnosed, untreated, gestational complications and unintended pregnancies, higher rates of mental health disorders, as well as substance use, which I think someone had astutely mentioned early on, as well as higher rates of chronic conditions. As you can imagine, kids that are involved with trafficking still have the same pediatric chronic conditions that other kids have, but they might not have as easy access and as ready access to their insulin if they have diabetes, to their albuterol if they have asthma. So they can have more frequent exacerbations and more severe exacerbations of those chronic medical conditions. Now, with that being said, we recognize that when a kid comes in and we're worried about trafficking, there are so many things that we're thinking about. We're thinking about where they're going to go. We're thinking about their safety. We're thinking about who they've interacted with. And a lot of times we can get in our own heads as healthcare providers. And so I like this slide to basically just break it down to not forgetting that our role is still the same. Our role is still to identify, to interact, intervene, and meet that kid where they are and to be able to support them in that moment. And so what a lot of that can be is addressing their unmet health needs. So if they are in DKA because they didn't have access to their medications, treating that and then starting to explore what are the circumstances that led to that acute presentation. Assisting with evidence collection. So for those of us that work in the sexual assault response team or the child abuse team, assisting with evidence collection when that is appropriate. So if a kid presents for an acute sexual assault, offering that, but not necessarily mandating or necessitating that. And then ideally, once we are able to determine a safe disposition, connecting that kid with aftercare that makes sense. These are the kids we're just simply handing them an informational handout or a brochure and expecting them to make follow-up phone calls on their own is realistically unrealistic. I think these are the kids that would really require a little bit more support, a little bit more outreach to be able to get them plugged in with the services that might be beneficial so that they can maximize their potential when they leave that physical setting. Sometimes scheduling that follow-up appointment and really checking in with them weekly or bi-weekly can be helpful to make sure that they do remember in the context of their life. So when we think about why kids present, as Hannah had mentioned, the vast majority of kids we do know are presenting for medical attention during their period of exploitation or trafficking. The numbers suggest that it's upwards of 80%. And the other piece that we know is that when it comes to sex trafficked youth or adolescents, the primary piece of their healthcare that has their buy-in or where they are most engaged is when it comes to their own sexual reproductive health. Again, we don't like to generalize, but there's virtually no one that likes getting an STD. There's virtually no one that is a little bit trepid or a little scared of having an unintended pregnancy. These are the things that really do matter, and they are concrete things that affect these kids on their day-to-day basis. So they might present acutely or recurrently for concerns about their vaginal discharge, about abnormal bleeding, about concern that they may have caught something. They may not say it in those exact words, but they will say, just want to check up. I just want to make sure everything's okay. Those are most often the reasons that they will self-present. The other thing that we do know about kids who are being trafficked is a lot of them do present psychiatrically for in crisis. So that could be for acute suicidality, acute behavioral aggression, or some other manifestation of trauma that they may be experiencing. Now, when it comes to their sexual reproductive health, hopefully this is relatively known for everyone on here. We're looking at baseline testing. These are the kids that I recognize that there are CDC guidelines for STD testing, and for a lot of adolescents, we're telling them, hey, get tested maybe once a year. These are the kids that we're usually testing a little bit more often, especially once you have that rapport and that relationship with them. We'll talk a little bit later in the presentation about the clinic that we have, but some of these kids over the course of a year come back monthly for testing because they're worried about something that they may have caught. Again, I recognize that that may not be realistic for everyone, but at least baseline testing. Urine gnats, so the urine aptomos, are really easy to get. It's non-invasive. Those will usually at most of our institutions include chlamydia, gonorrhea, trichomonas. Sometimes you have to add the trichomonas on top of this CT and GC. When we think about serum blood testing, there are some kids who say, no needles, but if we can convince them at least once or twice a year, if not more, to be able to kind of endure that, it can be helpful to check for HIV and syphilis. There is primarily adult literature that has been extrapolated from adults who were involved in sex work that encourages us to check for hepatitis B and C. I'll be honest, most of the pediatric literature doesn't really make us too worried about hepatitis C or hepatitis B, especially now that kids are immunized. But again, if you're getting blood work, it's not outside the realm of reasonable to be able to get that as well, at least once a year, maybe twice a year. Having conversations about prior STDs can certainly be helpful in terms of how long this kid may have been treated or what they may have been exposed to. As we all know, recurrent untreated STDs can have long-term issues on anatomy and fertility. And that is often one thing that a lot of these kids may not be thinking about in that moment. But if you do query what their future goals are, that is usually something that they're thinking about in the future. We hear quite commonly kids say, hey, I've never been loved, but I do want to have a kid of my own that will get that unconditional love. So they are looking for that in the future, and they may not be putting two and two together to recognize that these untreated recurrent STDs could affect that fertility and could affect that future that they're envisioning once they're out of their acute circumstances. Of course, a UPreg, so a urine pregnancy, is relatively easy, relatively straightforward. I imagine in most of our adolescent health settings, we are getting this pretty routinely. Having these conversations about contraception and prophylaxis, again, being honest, knowing the safety and unpredictability, as well as the transient nature of trafficking victimization, expecting someone to take oral contraceptives, so taking birth control pills every day around the same time regularly, is probably unrealistic. Again, we don't want to make that decision for them, but just providing that information is usually helpful. There are other forms of contraceptive, especially when we're thinking about long-acting reversible contraceptions or LARCs, that are a little bit easier. Thinking about depot, so having a kid come in and then knowing that they need to come back in 3 months is kind of two birds with one stone. One, keeping eyes on these kids and having a place for them to return to where they feel safe, and two, protecting them for that 3-month interval period as well. We have a number of kids that are interested in the Nexplanon, so that can be inserted into the arm, 3 to 5 years. We've had less kids that are interested in the IUDs. There's just something about the anatomic location of an IUD that I think freaks kids out a little bit. So that usually requires a little bit more of a conversation. And then of course, making sure that just given the transient nature of these kids and times that they may have been absent from care and may not have seen their primary care or their primary pediatrician, thinking about getting them plugged in with vaccinations and getting them caught up if that is the case. We've also had a lot of kids who are out in the world and they hear about COVID, but never really thought about the COVID vaccine for them. And then offering them and having that conversation that they're included in that can be pretty empowering and powerful as well. Now, these are a lot of the standard situational indicators. Again, these are pretty hard, and as the frontline clinician, you may not be privy to a lot of this. Some of these things happen behind the scenes during registration and whatnot, but things to consider that may raise your red flag when you're worried that there's a situation happening and you can't quite, your spidey sense is tingling, but you can't quite put your finger on it, is when kids are accompanied by an adult caretaker and it's not clear who exactly they are and what their relationship is. It's clearly not their mother or their father. It's clearly not their grandparent. There's just this adult that's answering all these questions, providing all of their registration information, kind of shushing them and taking over. Again, that's non-specific, but it is something that should just kind of percolate in the back of our mind as to, you know, what exactly is going on here. There are a lot of kids that struggle with remembering what their address is because they've moved around, because they've been AWOL or absent from care. There's kids that have bounced around, especially now with the advent of the different medical records that we have. For those of you that might use Epic, you might have access to Care Everywhere. Being able to see the different places that a kid is presented to can sometimes be helpful in putting together those missing pieces. Now, you know, I've given these presentations for years, and almost to the date, I've always said something like, no kid comes in with the chief complaint of human trafficking. I will say I have now officially had one kid that came in and said, hey, doc, I want to get out of sex trafficking. But outside of that one kid, almost no one comes in with that chief complaint. So that we're always thinking about what are we doing in our physical exam and our general observations that can, again, just raise that red flag just a little bit because we often don't know and we don't often have that identified individual in front of us. One, as Hannah had alluded to, thinking about the clothing and accessories that kid has. If you are a primary care pediatrician and you've known this kid and the family that they live with or that they've grown up with over the entirety of their life, and they are now suddenly coming in with these new Jordan sneakers that are $300-400, these new Gucci bags that might be hundreds, if not thousands of dollars. They might have multiple phones. Again, that is not a slam dunk, but it is something that should just pique our interest as to, you know, why that is the case, and something that we may be able to have a conversation about, not be accusatory towards, but certainly just have a conversation about. Thinking about tattoos in most of the states that we live and work in, so, you know, specifically Pennsylvania, we know that kids under the age of 18 require a parental consent for them to get a tattoo in a licensed official capacity or official facility that does tattoo work. I would venture a guess that the vast majority of our kids that have tattoos are not getting them done at a licensed shop. They're usually getting them done, you know, at a friend's or down the street or whatever it might be. So just querying us, you know, what's the significance of that? You know, what's that name that you have? What is that design? And then just having those questions. Most kids, you know, if it's just their grandmother's name, will just quickly tell you like, oh, it's my grandmother, it's my nana, you know, I love her, and I just wanted to represent her on my body. And that's usually a relatively easy conversation. And then there's some kids that will be a little bit more guarded, perhaps a little bit more evasive, and just might warrant a few more questions. Again, not a slam dunk, but something that we can do when we're in a patient encounter. And then, you know, these are probably relatively straightforward or self-explanatory. Thinking about various injuries, elucidating whether the injury that we're seeing is consistent with the mechanism that the kid is providing. The number of teenagers that we have that come in and say, oh, you know, I'm clumsy and I just like fell and hit my face directly on a doorknob. It's probably not as common as we hear it. It's a pretty unique injury mechanism. And yet again, something to think about. And these could be anywhere on the body. So thinking about not only the injuries that are most obvious to our naked eye, so that might be things on the face, but also thinking about certain genital injuries and injuries that may be marked underneath the clothing. Now we'll quickly just transition to a case example. So we have Adam, who is 15 years old, and he comes to a local urgent care. So a lot of our kids, again, do not necessarily know who their primary care is or have fallen out of care for their primary care for years. And so they may present to an urgent care and an emergency department setting, both pediatric or adult, as well as other reproductive drop-in centers. And so we have Adam, who lives in a group home, is accompanied by his group home staff. On conversation, you learn that he's 15, has a history of running away, quote unquote, going AWOL or absent from care, has an open case with CPS, and that's been on and off since he was 5 years old when he was noted to be a survivor of sexual abuse. Adam's mom has extensive law enforcement history involving, including substance use charges, and has, kind of been on and off involved in his care over time. If people feel comfortable, putting it in the chat or speaking up, we'd love to hear your voice. What are some vulnerabilities or risk factors that we see? And this is mostly going off of what Hannah had presented earlier. I would like to think that some of these are fairly obvious, and we're not always privy to a lot of this information when we see a kid acutely and we've never seen them before, but are there things that stand out to this in this vignette that clinicians would be like, hey, that combination of things makes me just a little bit worried. And it's okay if you don't want to speak. I will gladly. So I will lob this one up and answer it myself. So when we think about his abdominal pain, that is relatively non-specific, right? That could be constipation, that could be poor diet, that could be appendicitis, we don't know. We can also just think about like that could be referred pain from his genital areas. We know that that can happen with boys. When we think about this kid's life, we can imagine that it hasn't necessarily been easy. He's had child welfare involvement, and regardless of what we think about positives, negatives of child welfare involvement, we know that that can be stressful on individuals as well as their families, has had that for about 10 years, has a history of sexual trauma, has a history of being in different placements, has a history of what we would just consider to be, some realm of household dysfunction, where mom has been involved, but not necessarily parental substance use, checks kind of a lot of those boxes that we worry that make him a little bit more vulnerable to exploitation or someone taking advantage of that situation. From a medical standpoint, what should be evaluated? This is a kid where we worry about sexually transmitted infections. We think about some of the exposures that he may have had. Also, because he's been in and out of care, I would love to assume that group home staff has taken him to his annual visits for primary care, but I wouldn't entirely be confident that he is up to date on his immunizations and that he is all set from that standpoint. So when we're thinking about STD testing for him, would something to offer him, and I think he would be a candidate for, would be urine NATs, so the urine STI testing that we discussed, serum STI testing. Would also think about any other kind of exposures anatomically that he may have, like would this kid benefit from a rectal swab? Not something that we necessarily do all the time, but something that may be worth offering to this child. And then also thinking about, depending on where he's at in his life and where he's at in terms of his comfort in discussing this topic, if he is having some kind of concerning sexual exposures, regardless of whether he discloses acute trafficking or exploitation or not, thinking about, is he a HIV PEP, HIV PrEP candidate? Are these things that we could have a meaningful discussion with him about? So let's say, hey, you suspect CSEC. And that, honestly, getting to that point is commendable. It's often not on a lot of our radar. So even getting to that point, I want to say that is awesome. And so what do we do? Because that can be pretty perplexing once we even get to that point. I want to be clear, there is no set clear algorithm or set protocol. Different clinicians, different providers across the country, across institutions do this just a little bit differently. Something that we have found, so I currently work at CHOP, I previously trained at Brown, and something that, I think a lot of us, perhaps kindred spirits or like-minded folks, have realized is that a lot of the conversations that we're having with these kids are pretty similar to other difficult or challenging conversations that we have kids, regardless of discipline or regardless of topic. And so it's often easiest to start broad and then get a little bit more specific, what we call the funnel approach, as we develop that relationship, as we develop that rapport. And this doesn't necessarily always have to be in one go. I recognize that for those of us that may work in the emergency department or urgent care, you feel like, hey, I have to have all the answers in that one time. But if we can try to make this, just recognize that this can be a difficult conversation. So trying to break this up over time or providing warm handoffs can be helpful in supporting these youth. I would imagine that most of us have at least heard of the HEADS assessment. So again, this is more of a broad or universal adolescent psychosocial review of systems, thinking about when we're asking kids about their home life, not only where they live, but also thinking about, hey, do you spend time away from home? Kind of insinuating that idea of, if you've ever run away, like, where are you going? If you're couch surfing, where are you going? Why is that happening? What at home is kind of encouraging you to leave, and then what are you doing when you're out? Again, kids may blow that off, but it is at least something worth asking about, inquiring about, thinking about, are they going to school? But not only where do you go to school and what grade are you in, do you have, how is attendance? Are you having any challenges with attendance? Most kids who go to school every single day have probably never even heard of the word truancy. Like, that is a concept that's not even on their radars. For kids who have been truant and have been where that's an issue that's been addressed, they often know about truancy core. They often know about the rules and regulations more than kind of other adolescents. Thinking about employment, again, a lot of our kids who are between the ages of 14 and 16, what meaningful employment opportunities really are there? Realistically, it's probably the grocery store. It might be some other kind of retail stores. Thinking about, how are you buying the things that you want? Are there ways that you're getting them? Oh, you got new sneakers. Did McDonald's help pay for that? Or is there something else that maybe we can kind of inquire about? And then the rest of the HEADS assessment is relatively straightforward. When we think about activities, we think about substances, we think about sexual activity and safety and all of those things. And then if there are some pings that we get, again, if our spidey sense tingles from there, we can go down to perhaps some broader questions. One of the things that a lot of us have found helpful is taking the onus off the individual. I've met virtually no one that comes in immediately and is like, hey, I want to talk about these things that are happening to me. It's often a lot easier for kids to talk about one of their peers or one of their friends or someone else that they know. So sometimes gauging what kids know about trafficking or escorting or those types of things can be helpful. And a lot of kids may be like, oh, I would never do that. That's gross. I would never put myself in that position. But then might pivot and say, hey, but my best friend has spent times at these motels or hotels. And again, they might be being honest. They might be being completely honest where it hasn't affected them at this point. But I would argue that if they're in that situation, if some of their best friends or acquaintances are in that situation, they're probably not too far off. And when we're thinking about degrees of separation, that kid is probably pretty high risk as is. And so that might be an opportunity to intervene, to have a conversation and think about some of the safety consequences and assessments of that. And then most specifically, for those of you that may have read some of the AAP guidelines, when we think of Jordan Greenbaum down in Atlanta, some of the work that she has done, she has come up with some focus questions. I would encourage folks not necessarily to read these verbatim, but there are more focused specific questions that you can always ask kids about, hey, has anyone ever asked you to do X, Y, or Z? I would always encourage folks to put them into your own words, because if you just read them from the checklist, it feels very clunky and kids off the bat know that you're just reading from a checklist. But there are more focused questions that you can ask, especially with the advent of social media and different technologies, to think about, has this ever happened to you online? Has anyone ever kind of solicited you in your DMs and things like that? There are a ton of words and some beautiful colors on here, so I'm actually not going to go through this. But for those of you, this is mostly just reflecting what we discussed on the previous slide. This is actually a little bit of a flow diagram that, for those of you that know Amy Goldberg from Brown, who's a child abuse pediatrician, published in Hospital Pediatrics back in 2019. And she mostly just is encouraging folks to go through this funnel approach where you start broad and then you kind of work your way down. And again, not necessarily, the end is not always the goal. It really is trying to have this conversation, engaging what this kid knows about this potential lifestyle, any potential exposures that they may have had, and things that we might be able to counsel on and provide anticipatory guidance on. Now, when we think about best practices, there is no standardizable algorithm. There's no just kind of general guideline. I would encourage everyone to be the things that I think we already are, which is kind, compassionate, non-judgmental. But I think what we know, at least over the last decade of trafficking in CSEC literature, is that the modern medical model really doesn't cater to these kids. When we think about well child visits being 20 minutes and trying to explore all of the potential risk factors and acute vulnerabilities that a kid may have, that is just simply not realistic. So a lot of these things may not necessarily be addressed in that 20-minute appointment, but can be as we kind of continue to develop that relationship, earn that trust, and have telephone outreach or other creative ways to stay in touch with these kids. So really being patient-centered for a lot of our kids, because they've previously had child welfare involvement, perhaps may have had juvenile justice involvement, a lot of their medical appointments have already been scheduled or requested by someone else, right? Like it might be their DHS or their CPS worker. It might be someone who is their child advocate. It might be their lawyer. It's often not, these adolescents usually do not have the ability to make their own appointments. They often do not have the ability to call up and be like, hey, I'm worried about this. They usually have to tell another authority figure to make those appointments. So sometimes when kids come in, leaving it up to them as to how they direct their own agenda can be pretty empowering. And it's not something that they've probably often experienced on their own. Being pretty flexible and accommodating is also super helpful. Again, as we are coming out of this pandemic, we recognize that scheduled appointments are rare, right? Like we're all booked out weeks to months away. It's pretty quick for a lot of our facilities, a lot of our institutions to have these hard cutoffs of, hey, if someone is 15 minutes late, we don't see them. If someone misses more than 2 appointments, they're discharged from the practice, because you know that another kid or another patient is just going to fill that slot. But I think that does quite a bit of a disservice and is an injustice, especially to these kids who may really be trying to make it to this appointment, but just have numerous barriers that are getting in the way. Being honest and completely transparent about the benefits, but also the limitations of adolescent privacy and confidentiality are really, really important. Anytime that we have a kid that comes in that we're worried about trafficking, or really any adolescent, we pretty much right off the bat just let them know, like, hey, these are kind of what we're able to do. We do separate, so we're able to speak with adolescents individually away from their caretakers or other adults that might be accompanying them. But then we're also emphasizing that, hey, everything that we're talking about is private and confidential, except for X, Y, and Z, so that they know. Because I think blindsiding a kid can often erode some of that trust that you may have developed over the course of that conversation. And then for a lot of these kids, I think we all probably already do this. We really try our best to get all of our colleagues on board, whether it's social work, whether it's CPS, to try to come up with a safe disposition. Going to be a little bit of a bearer of bad news, and kind of just acknowledge that the vast majority of times, guys, like there is really no perfect, ideal, safe disposition. You know, I think we would like to think that the things that we see on television or in movies where a kid has been identified, they've been quote unquote recovered, and then the rest of their life is cake, is really just not accurate. A lot of the contextual circumstances and vulnerabilities that led to them being involved in trafficking in the first place usually do not go away after they've been identified. They're usually still there, if not amplified. And so one of the ways that we can try to empower youth, again, especially kids who have been extensively systems involved and may not feel like they have much of an individual voice, is really just empowering them for the decisions that they may be able to make. So I think a lot of that goes back to educating kids on the sexual reproductive health things, and really providing some of those concrete examples as to why we care about these things and how they may relate to that child. A lot of our kids who have experienced trauma have a hard time thinking about the long term, right? Like for most of us on this call, we're thinking about, hey, to get from point A to point B to point C, this is just kind of how life goes. And these are the decisions that we need to make. And these are the things that we need to avoid to be able to achieve our goals. For a lot of our kids, thinking about, hey, I want to be a pediatrician. We have a bunch of kids that say, hey, I want to be a pediatrician. And yet they've attended school maybe like 40% of the year. And for them to make that connect of, well, first I have to attend school, then I have to graduate, then I have to go to college, is not something that is intuitive to them. So sometimes having these conversations of, hey, I hear that you have this wonderful goal. How do we think getting pregnant at this time would affect that? You know, would it Would it be helpful? Would it potentially influence your decision? Would that be something that you want? Is maybe a little bit more concrete, and then setting that out in a way that might make a little bit more sense to them. And then also allowing them to help make decisions on their own. So, there's, again, when kids are involved with the system, there's not a whole lot of decisions that they really are able to independently make, but if there are options that we're able to offer of like, hey, my understanding from your worker is that they're thinking about this placement versus this placement. Can we just go through the pros and cons of each of these? And what do you think? And we will try to honor that as best as we can. When we're thinking about, hey, you are interested in contraception, let me lay out these options. What do you think is the best fit for you? And then mostly just to reiterate, I think it's one thing for you guys to hear me say it or Hannah say it or Michelle say it. I think one of the things that we know from qualitative surveys from survivors is that they really don't expect us to be experts on the sex trade or life on the streets. I know a lot of us sometimes think like, hey, I've never personally had these experiences. How could I ever relate? A lot of these kids really just want us to treat them like we treat everyone else. And that's with respect. And where we're really listening, because a lot of these kids have had, pretty adult experiences or things that we may not hear all the time. I think sometimes we want to be overly paternalistic or overly maternalistic and be like, hey, you should do this, or like you should do that, without really acknowledging that their circumstances are so complex that there might be some rationale as to why they're making the decisions that they do. Trying to encourage them without, again, overly pushing our own agenda on them is something that I think we all struggle with. When we walk in the room, we want to be like, hey, if you did X, Y, and Z, your life would definitely be on the up. But it's not always that simple. And explaining that to a kid that has had a variety of traumatic experiences, again, may not sit in the same way. The most important thing that trafficking survivors almost always say universally is that a lot of their negative healthcare experiences are tied to feeling judged, where if someone, we're all trained to ask, last, encounter for sexual activity, number of sexual partners. If that kid says something that may be outside of what we consider to be our norm, really being careful to not reflect that in how we react. I think the masks with COVID have been a little bit helpful in terms of masking some of our facial expressions, but the kid says that at 16 years old, they've had 20 plus sexual partners. Again, that might fall outside of the norm of what we consider to be our normal standard deviation, but we shouldn't let them know that, right? Like we should be able to be that holding container where anything they throw at us can stick, and we're able to kind of process that in the moment and support them. Because if they can't say it to us, who are they going to say it to and be able to feel safe about it? The other piece is, I know sometimes as providers and clinicians, we worry that, hey, if we bring up trafficking or if we bring up trauma, that's just going to re-traumatize them. And so we might as well just keep avoiding it, keep avoiding it, keep avoiding it. As most of us that work in the child abuse field, I think we all respect that. I think most of us don't necessarily try to get all the vivid graphic details. We leave a lot of that to the CACs, to forensic interviews. With that being said, I think there is core information that can help guide our medical decision-making, and we shouldn't be afraid to be able to kind of get that. And so when, especially, again, this is probably most easiest when it comes to sexual reproductive health, thinking about the information that we need to be able to provide guidance or provide information on what we think to be appropriate testing, treatment, contraception, whatever that might be, is not a bad thing. And kids usually, as long as it's done in a safe, compassionate manner, in a non-judgmental manner, do not feel like they're being overly traumatized. If we are trying to ask all these nitty-gritty details about their trafficker and all these little things that happen, I think sometimes that can be a little bit too much, especially because a lot of that information for us is not something that's directly impacting our clinical judgment. But outside of that, kids do really welcome us having those conversations. The other piece that came out of this qualitative study from the CHOP ED is that kids also prefer to have multiple team members have that conversation, instead of it just being only social work has that conversation. And then kids knowing like, oh, this is why the social worker is coming to meet me. They also recognize that, for a lot of medical teams, the physician kind of is that team leader. And so they also want, the doctor to be able to have that conversation with them as well, and then also brainstorm options with the social worker and other members of the team. And before we kind of pivot over to some of the trauma manifestations, I think it really is important to recognize that a lot of our kids may come in with some form of acute physical injury. Realistically, and again, not to generalize too much, realistically, the vast majority of kids with physical injuries will recover and heal from those in a relatively short amount of time. You know, I don't want to minimize fractures and other kind of cutaneous injuries, but usually those will heal within a reasonable amount of time. It's really the mental health manifestations of what they've experienced, and that could be preceding trauma prior to their exploitation or trafficking, the trauma that they experienced during that trafficking. And then a lot of our kids also talk about the stigma related to rehabilitation and reintegration after. And I think that's truly heartbreaking, is that we've had all these kids who are so resilient and have powered through all of these experiences and exposures that they've had. And yet they're often saying like, hey, you know, I could deal with those, I can live with those, but it's really how people treat me now when they call me a prostitute, when they say that I'm dirty, when they say that I'm damaged, when they say that I'm broken, or the way that people look at me and talk about me is really what's affecting me. And that's really challenging because I think that is more of our societal response. Like we should really be welcoming and embracing these kids in so that reintegrating and rehabilitating is easy. But I've had almost no kids that have said that that piece is easy. Almost after identification and quote unquote recovery, almost all of these kids struggle because someone knows about what's happened to them. And a lot of people will point that out in a negative way. Michelle, if I can actually just quickly hand it over to you to introduce this video before we talk about trauma. Thank you.
Thank you. That was very thorough. Again, this is another survivor story, and I think that talking about this in this context is so important. But again, just sharing some input from survivors about their experience with medical emergencies and how it's affected their trajectory is super important. So last video of the slideshow, I think, but we're gonna jump right in.
I had found out that there are these things called escort services. And I thought that I was like moving up, you know, a step. And it's the same. I mean, it's the same. You're just not getting into somebody's car, you're walking into somebody's house, you know, or you're walking into a hotel room with a stranger. I mean, they still hurt you.
Everything was fine and dandy until the first time I said no.
A guy woke up, realized I was black. That's what he wanted the night before, but he woke up, realized I was black, and all hell broke loose in the room.
Una de las veces que recuerdo, el hombre me apretó tanto la boca que me rompió los dientes.
He broke my wrist.
I got my hair cut off, sliced my face. I've had guns put to my head.
Thrown out of cars, beat with a bat, had guns to my head.
And I remember sitting in the hospital, my chest was so heavy and I thought I was having a heart attack and I couldn't breathe.
I was terrified that this man who had just tried to kill me was going to come back and finish the job.
I was definitely afraid of being caught and found out. And if someone had said, I can help you on that day, especially on that day, I would have taken it.
I have this weird relationship with hospitals. Like, I'll go in for surgery because I like that they take care of you, you know? And that's what I appreciated. I will say that the nurses I remember in the emergency room showed kindness and compassion, but nobody asked me anything.
People who work on the front lines, like health professionals, can be such an important time, especially in a medical field. That might be the only time that woman is away from her trafficker.
I think that's definitely a great opportunity for someone to be kind of a first-line identifier. There was a lot of training that went to medical people, social workers in hospitals, to identify, hey, this person might be victim of some type of child abuse or domestic violence. I don't really see much of that on the trafficking side.
When I had my daughter, walked 2 blocks in my socks to get a cab by myself and went to the hospital and so scared. And I remember they asked, would there anybody be coming? And he didn't show up. And then he didn't show up and didn't show up. And I was supposed to be checked out of the hospital like 11. He didn't show up till 5. And I'm just waiting there, have no money. You know, I think that would have been odd.
I had over 18 emergency room visits. I was a child. I was out there. I was walking on the streets. You could tell I looked young. I should have been in school. To them, I was a prostitute. They treated me like I was dirty and that I deserved to have this abuse happen to me.
One time I went to the doctor, and the doctor I went to urgent care. I told him that I was a prostitute and I was scared of what I might have. And he was like, well, you obviously have an STD. And just gave me some medicine, told me to go home. It turns out that I didn't have an STD. I just had like a cyst that bursted.
I had just been almost murdered. Nobody came to talk to me. Nobody. And the X-ray technicians decided to sexually abuse me while I was there. All I could think was this is all I am. I mean, this is how it's going to be for the rest of my life. I mean, I'm looked at as nothing but an object.
Wanting to feel like someone cares about you, someone wants to help you, there's someone there who can and will and wants to take care of you. That's very human. And maybe that's the route. I think it's just trying to make that initial inroad and, the initial kind of identification that's important.
I remember the doctor saying, "Can I talk to you for a minute?" And I was like, "Yeah." And he asked me, was I under a lot of stress? He asked me, "Are you going to be okay?" I said, "Yeah, I'll be fine. I think that I'm overworked." And he said, "Are you sure?" I couldn't tell him out of embarrassment. Like, I felt like I was a strong woman. I am a strong woman. He never guided me to any other intervention, but just his words and him knowing was important to me.
So I think that video really speaks to how society views survivors and how they view themselves based on experiences that they've had. In our more extended training, we are going to do a deeper dive into trauma and how that manifests itself. But just so that you can see, we define trauma as a psychologically distressing event that's outside the range of the usual human experience. We've all experienced stressors in our lives, things that situations that have been stressful or cause deep anxiety, other behavioral symptoms. But children who have experienced trauma, a lot of times they show us with their behaviors. So the behavioral symptoms that we see in these kids are a direct result of coping with adversity. We might identify them as maladaptive behaviors, but really they are misapplied survival skills because these kids are experiencing complex trauma. They're experiencing stressors that are repetitive, prolonged, or cumulative. They're often interpersonal. So we talked about the relationship factors here, where it's often direct harm or exploitation at the hands of someone that they trust, someone that they're depending on. That could be intrafamilial trafficking. So it could be someone that they're viewing as a primary caregiver, whether that's a mom, dad, aunt, uncle, grandparent, or another responsible adult, someone that they are trusting. Or it could be an intimate partnership. So it could be someone that they're viewing as a boyfriend, girlfriend, friend, someone that they are relying on for those basic needs. And then we can't talk enough about the developmentally vulnerable times in their lives. So this is happening at age 12, 14, 16, times where, like Anish said, they can't even really think beyond the scope of what's happening in the here and now. They know that they want to get to point C, D, E, F, but they're not seeing the A, B, the parts where they can really change the trajectory of their lives and get out of the situation that they're in. We know that these kids are appearing different ways. So they might be kids that are coming in. If you think back to that first vignette that we shared, this child might appear deceptive, manipulative, uncooperative. She's saying, I'm going through my own stuff. She's in a state of crisis. She might even be protecting the person who is causing that harm to her. Again, these are maladaptive behaviors that kept them alive in their trafficking situation. But when you're dealing with them as a service provider, it can be super frustrating. When we talk to law enforcement, we say, hey, we know this is frustrating. This might hinder your investigation. When we talk to child protective service workers or prosecutors, like, we know that it's difficult to work with this kid. It's hard to get them into services. It's hard to talk about why birth control is so important or why you need to do this STI testing. But just keep in mind, they are going through a really difficult time. And there's a reason why it's manifesting itself in this way. There is an overall reluctance to disclose. Again, these kids fear arrest. They might not know that in 2018, the law changed and they can't be charged with prostitution. They are not a child prostitute. They are a victim of a crime. But oftentimes there's other crimes that might be happening at the same time. Maybe they're getting picked up on shoplifting charges. Maybe they're involved with drug trade. Maybe they're involved with other crimes that unfortunately that's where our society is right now, that they might be in the juvenile detention center because of other crimes, but really they are a victim of a crime. Again, there's that fear of the perpetrator, a loyalty towards the perpetrator, because this is someone that they trust. This might be the only person that has really shown them any love or affection in their 16 years of life up to this point. So they might protect that person, and they're not going to come in and be like, here's his name, his phone number, here's where he's at right now, and if you want to go arrest him, like, go for it. That's probably not going to happen. So there's this reluctance to disclose any details about this person. I think Anisha really talked about the feelings of shame or humiliation. Unfortunately, stigma is a huge factor here that plays a role. And we talked about how society views these kids as broken or as child prostitutes still, or as someone who just is kind of a throwaway, a lost cause. So there's these intense feelings of shame. And I think he talked a lot about how you can kind of change how you talk to them. You do need to get some of these details, but maybe not getting into the nitty-gritty details, or just changing the way you talk to them can help. And then there's just this overall lack of awareness about their victimization. Again, we do not need elements of force, fraud, or coercion to legally bring charges of child sex trafficking or commercial sexual exploitation of children. They might not know that. And if there aren't those elements of force, fraud, and coercion, they might feel that they're not a victim, that they chose this life, that they chose to exchange a sex act in exchange for a place to stay, or in exchange for drugs or access to substances, or for those new Jordans, you know what I mean? That luxury item. So they're not seeing themselves as a victim. And that's one of the hardest parts to get to that recovery stage, is to really self-identify as a victim in need of services. Trauma bonding is a very interesting phenomenon that we see with a lot of these kids. Back to Stockholm syndrome, we now call it trauma bonding, but these kids develop emotional attachments to their abuser. They're in these unique situations where they're dealing with these dependency and isolation. It brings them into prolonged contact with this abuser, and it creates this really special type of relationship, which is one of coercive control. And perpetrators know this. Their overall goal is to instill in the victim this overall not only this fear of death, but this immense gratitude for being allowed to live. They know what this person is capable of. Maybe they know that they have access to weapons. They know where they keep their guns. They know that they are a good shot. They've seen the violence that they've done towards other people, and they feel this immense relief when they're spared that violence. So what does trauma bonding look like? Again, I'm breezing through these, but in our longer presentation, we're really going to do a deeper dive into like what this could look like. And you might not see it in an urgent care setting or in a hospital setting, but it's really important for survivor or for service providers to understand that trauma bonds run deep, and it really can affect your interaction with this child at any point in their journey. But there are mutual positive feelings by the child towards the abuser and vice versa. There's going to be negative feelings towards you. So hopefully you can put those feelings aside and know that there's a reason why they might push you away. But don't run when they push you. They might believe that they have some sort of control over the abuse. They're hypervigilant towards the abuser's needs. At times they're supporting the abuser. And they also are blaming themselves for what has happened or the situation that they're in. Next, we're going to talk about the trauma-informed response. You can see this is an outside picture of Mission Kids. Hopefully they are getting services at a place like a child advocacy center, but Anisha is really going to walk through the APC clinics to tell you a little bit more about it.
Thanks, Michelle. So everyone, again, there's no necessarily like generalizable standard or best practice clinical model for these kids right now. There are different places that are doing different innovative and pretty cool things. I want to give a quick shout out to the CARES Clinic in Washington, DC. I want to give a quick shout out to Mount Sinai's Adolescent Health Center. Those are some of our primary influences in reading their experiences and some of the data that they had published over the last few years. So the Adolescent Protection Collaborative, or the APC Clinic, is something that we launched at CHOP last July. So again, going on about a year. And our goal was to really cater to the needs of kids in Philadelphia and some of the surrounding communities in terms of reducing the fragmentation of care and access to medical care for sex trafficked youth in our area. What we knew from a host of meetings, so we had, I would say, probably between 30 and 50 meetings with community partners, stakeholders in Philadelphia, who regularly interface with trafficked youth to try to figure out what the needs were. And I think basically the universal consensus was that a lot of these kids were transient, kind of hard to track down and reach, and then also accessing care, but accessing care at the adult Pennsylvania hospitals or Planned Parenthood or other drop-ins without any kind of continuity or consistency. And a lot of them were really falling out of care of their primary care physicians. So what we aimed to do was create a specialized medical home model that provided co-located and coordinated care. And so we are in clinic approximately twice a month, and it's staffed by myself, representing the child abuse or child protection team, an adolescent medicine physician, and then we have a grant-funded position for our social worker, our case manager, who plays the role of a clinical services coordinator. And so we all meet with each of the kids every time that they come in, and it really just depends on what the kid needs at individual visits. So if they are primarily there for mental health needs or something, they might just primarily meet with the social worker, and we'll kind of come in and say hi for continuity and FaceTime. If they need something that is a little bit more forensic or a little bit more sexual reproductive health, either myself or the adolescent medicine doc will spend a little bit more time with them. But to be honest, a lot of these kids, their reputations precede them. But then once they come to our clinic and get comfortable, they sometimes we feel like they're just kind of coming in to just shoot the breeze, I guess is the way that we'll say it. And they'll just kind of come to hang out because they know that there's at least a group of people here that just genuinely care about them and aren't really forcing an agenda on them. As we had talked about previously, sexual reproductive health really is a primary source of buy-in for this population. Again, not for everyone, but at least I would say the majority. One of the reasons that we actually created the APC clinic within one of the primary care settings in West Philadelphia is because that primary care setting, which is the CareBots Pediatric Care Center, is Title X federally funded. So that streamlines access to sexual reproductive health services. And it also really just kind of eliminates any barriers to access for anyone, regardless of age, gender, regardless of where they live, regardless of whether they have insurance or not. And so that was our kind of primary goal in our idea during that period of conceptualization, that this would fit most of the needs that our kids need. Next, again, as I've probably really just repeated throughout this presentation, is really having a youth-directed agenda. When kids come in to see us, we try not to bombard them with a lot of questionnaires and screeners. I recognize that medicine in 2022 has a lot of just screeners, and we're screening for this and we're referring here and triaging and all that. We try to leave it relatively brief and really focus in on, I really usually point to one question on the questionnaire, and it says like, what would you most like out of this visit? And have the kids kind of write that in free text, and then they can circle other things if they need to. And we usually just focus in on that. If there are other things that we recommend or encourage, we'll bring them up, but we'll try not to belabor that unless the kid is actually expresses interest in. And the other piece is, I think we recognize that we try to do the very best that we can. I think we really try to connect and have been able to develop relationships with these kids, but we try to be realistic, right? Like none of us have the savior complex. We recognize that we are a small piece of the puzzle, and that as much as we would like to be there for these kids, we can't do it on our own, right? Like 3 people cannot solve all the issues and quote unquote fix the circumstances that these kids are in. We really try to bring in other team members that we know personally that we can vouch for, and then try to put these kids in contact with them. And part of that is through our community partners and stakeholders, of which there are many, but we also created a clinic-specific community advisory committee of people in the community that have offered resources and services for our kids. For example, we have a woman that owns a local yoga studio. As any of us that have ever, dabbled in yoga, we know that for most of us, it's probably pretty cost prohibitive. It is fairly expensive to be able to plug in with the yoga studio and be able to attend. So we actually have a woman that owns a yoga studio that says, hey, if any of your kids are interested, they have free access to our studio, free access to our online virtual library, and just like let us know. We also have connections with UPenn Dental as well as UPenn OBGYN in case kids need to get plugged in. We've mostly created this committee so that we would have experts in the lay of the land that would be able to kind of get kids plugged in for things that might fall outside of our expertise or outside of our scope. This is just a long list of some of the clinical services that we offer. As you can see, most of it is related to sexual reproductive health. We also offer kids to be able to transition their primary care to us if they want. Just to be clear, that is not a requirement. That is only, if kids are like, hey, I honestly have no idea who my PCP is. You guys aren't the worst. I'll keep coming back here if that's cool. And then we can formally transition that. Or they might just say, hey, you guys are the sexual reproductive health doctors, and I'm going to keep coming back here for this, but like, I'm happy to just get my annual shots at this place that I live nearby. And so it's totally up to them. One of the recent collaborations that we're really excited about is we are finalizing and formalizing a collaboration with CHOP Psychiatry to be able to provide expedited referrals for psychotropic medication management and consultation with two of their psychiatrists, where we recognize that a lot of our kids have, 100% of our kids have some form of mental health comorbidity. It might be acute, it might be chronic, it might have been in the past. And yet we know that a lot of these kids really don't access mental health services, even if they are offered. And especially because of the long wait times, and for providers that don't necessarily understand their circumstances. So might be a little bit more stringent about appointment attendance and discharging from the practice. So we have these connections with CHOP Psychiatry that will be able to get these kids in within a week or two. And ideally that'll help. We'll try to be a little bit creative with telehealth. So that's a little bit less of an appointment attendance burden on the child. Before I kind of jump through our pilot data, I do want to mention one of the things that I think was important for us is that part of our grant funding included funding for transportation facilitation. We recognize that for a lot of these kids that are absent from care or AWOL, they may be literally anywhere in the community in Philadelphia or outside. And so we provide, with our hospitality team, we offer these Lyft services that are able to pick up kids wherever they're at, bring them to clinic, and then return them back wherever they want. When we initially proposed this model, we had hoped to meaningfully interface with somewhere between 30 and 40 kids in the first calendar year. We mostly based these numbers off of what we knew about kids interfacing with the Trafficking Diversionary Court in Philadelphia, as well as the CAC and some other places that publish their data. And the good news is, I think, we pretty much came close to hitting that mark. We received 31 referrals in this first year. We've been able to track down and have 25 of those kids attend at least one appointment, which is 83%, which I think has exceeded kind of our expectations, especially when we think about the narrative that is out there with these kids is that they are an invisible population. They're so transient that it's like hard to really commit healthcare services to them, because who knows if they'll actually utilize them. And hopefully we can be part of reversing that narrative and showing like, hey, if you do build it, and if you build it in a way that is meaningful to these kids, they actually will come. Out of the 100 appointments that we had scheduled, we had attendance rates for 61 of them, so about 61%, which when we compare to some of our other CHOP clinics is on par or has exceeded, especially during the pandemic. So we're happy with that. I think what we're most happy about is some of the indirect proxy measures of what we consider to be, measures of rapport or relationships. And that's, the majority of our kids, so more than half of our kids have opted to follow up. So it's not just like, hey, they came one time, they were like, man, you guys suck, and then they just disappeared. It's actually like they came, they were like, hey, this is not too bad, and they decided to come back. So we've actually had kids come from one follow-up up to 7 follow-ups just over the course of a year. We've also have kids that met us and were just like, hey, we can't necessarily come back on the same day, but if you guys vouch for these other providers, we'll come back on another day. And we've been able to facilitate that, which I think is important to us, because we also don't want any of our patients to be entirely reliant on or dependent on us. We want them to have a good experience with us so that they can carry that forward with their other healthcare experiences in the future. I think we are probably not surprised, but like a little bit shook by just how high the rates of STIs have been. Out of the 25 kids that we've seen, 14 of them, so about 56%, have tested positive for an STI, and most commonly that's been chlamydia, then trichomonas, then gonorrhea. And then when we're counting concomitant and recurrent STIs, even just within that cohort of 25 kids, we've actually diagnosed and treated 22 STIs, which again is unfortunately quite high. We will say that about 70% of our kids have utilized or been open to utilizing long-acting reversible contraception. And again, another thing that I think we feel good about is that the majority of our kids have engaged in patient-initiated outreach, where they are able to reach out to us after their appointment with a question or a follow-up query or concern or whatever they might have. For those of you that might be more visually, graphically oriented, I've put this slide up. This is mostly just to reflect in-person clinic visits. So as you can see, it varies from 1 to 7. And with a lot of our kids, especially when we're thinking about adolescents, for them to show up 2, 3, 4, 5, 6, 7 times in this course of a calendar year is something that makes us feel like, hey, they are at least gleaning some benefit from this. And so that averages out to about 2 to 3 visits per patient. And I know that this is probably a little bit confusing, but in addition to those in-person clinic visits, we also log the telephone contacts. And I want to be clear, this is not like telephone therapy. These are not hour-long conversations, but these are check-ins on different days between myself or a social worker, whoever it might be, to update on laboratory results, just check in. Sometimes kids call us just to tell us about their day. Sometimes kids will call and just be like, hey, I just want to let you know I got a job at McDonald's, or I got back into school. And it just gives them an opportunity, and for us to kind of applaud or cheerlead that and support them with those little victories that might come up. So over the course of the year, we have totaled those 61 in-clinic visits, but also had, about 280 telephone contacts. So about 300 plus contacts over the course of the year, about 14 contacts per kid, which helps just keep tabs with them, especially because their lives are often very unpredictable. I'd say out of these 25, almost none of them, maybe 1 or 2 have had like pretty stable trajectories. The rest of them have had some kind of upheaval in their social or household. Some of you might be wondering, like, where are these kids coming from? We primarily try to partner with folks in the community that are already identifying these kids, so that, it's already been identified, it's already been reported to Childline. That legal investigative piece is already kind of simultaneously happening, and we can mostly fit that medical and supportive role. It just makes it easier, to be honest. So most of our referrals are from our community partners and stakeholders. We have recently been opening it up to more healthcare providers within the CHOP community. I will say we're still trying to work through that. As you guys can imagine, when kids get admitted, the inpatient team will really kind of hone in on the acute stuff, whether that's treatment, social disposition, whatever, and then they'll just kind of like toss out this referral to our clinic. And it makes it a little bit harder than when we have some of our community partners that know these kids for a period of time and are able to like track down different contacts. So that is just something that we're kind of trial and error and kind of working through right now as to how can we make that more universal and easier to navigate throughout and across the board. And I'll pass it off to Michelle from Montco.
Yeah, we're going to share a little bit more about Montgomery County and I think why we are uniquely positioned to talk about this work that we're doing here in Montgomery County. So we're very fortunate that in 2019, we received a grant to actually do a deep dive and look at what we were doing in our community for these kids. We've talked about the complexity of their needs. We've talked about how we need this collaborative approach. But in 2019, we just weren't there yet. So we did receive a grant. We worked with over 20 partner agencies to create this systematic response to trafficking. It took a lot of work. I'm not here to say that it was like sunshine and daisies and that everything is perfect. But it really was a good collaborative effort where we created these interagency relationships. And like Anish said, we knew that there was a need for a comprehensive network. There's no one person that can do it all. You need the buy-in of a lot of stakeholders. So this took a lot of work with our district attorneys, with multiple victim advocacy agencies in Montgomery County and the surrounding communities. We created this sex trafficking task force where there's people that are at the front line of creating and increasing collaboration. We know that it takes a multidisciplinary team approach, just as it does with any child abuse case, but if not more so. We need more of that, where service providers, advocates, counselors, again, our district attorney, our probation officers, law enforcement are combining to meet the needs of these kids. Even in working with defense attorneys, where they can be advocates for victims as they navigate the criminal justice system. We said that a lot of times they already have systems involvement. So it's really important to have people understand that. And then survivor leaders, we really do need to weigh the voices of survivors. They are experts in this field. Like Anish said, sometimes as service providers, it's hard to say, I haven't walked in those shoes and I haven't experienced this, so I'm not sure how to meet your needs. But why not ask the experts in the field, which are people who have experienced this? Like, what would you have liked to see? What would have been different for you? What questions could have I asked in a different way? Or what could we have provided for you that might have helped you get out of the life, stay out of the life, and be on that better trajectory towards following up with me to tell me that you got a job at McDonald's, or that you're attending school regularly and maybe you do still want to be a pediatrician and you're doing steps A, B, C to get to point D. So it's been a really interesting, awesome past couple of years that we've been working on this. Like Hannah said, we did serve 54 suspected victims of child sex trafficking in Montgomery County in 2021. This graph just shows you where we were at in 2016, 2017, 2018, before we really were able to put the resources in, do the research, collect the data, spread awareness about what was available for kids. And then we started seeing more kids, we were identifying more kids and providing those services. That doesn't mean that 54 out of 54 children did a forensic interview. They're just not there yet a lot of the time. We do have a CSEC advocate coordinator who works with these kids, who builds rapport, starts working with them early on. And she'll tell you that I think 53 out of 54 of those kids we saw in 2021 did not self-identify as a victim in need of services. A lot of times they felt that what they were doing was consensual, or that it was something that they chose to do. But we're getting better at identifying these kids. Again, we're working with the investigators on the front lines, whether it's CPS or law enforcement, to better identify these kids who might need help, letting them know that it is a mandated report. You do need to make that child line report, and then really triaging them and getting it to the right person for services. So we're really proud of the work that we're doing. We are providing, like I said, these trainings for different disciplines. We did it across Montgomery County. Now we're taking it on the road and we're doing it across the state of Pennsylvania. So if this is something in your community that you're interested in, please let us know. We would love to provide it for your community. Abby and Hannah also do consultations with multiple counties across Pennsylvania. I think we're at 4 that we're doing, to really see where they're at, share, obstacles that we overcame, lessons learned along the way, so that more communities in Pennsylvania can meet the comprehensive needs. Hannah, anything else that you want to share about Montgomery County or parts that you think would be helpful?
I think you covered it, Michelle.
Awesome. Well, so this is our information. If you scan that, it'll take you to our website, but screenshot this, we'll send it out. If you have any questions, I know sometimes that you walk away or you're driving home and you think of questions or maybe things that we didn't answer, but we are here to talk to you. We're here to share information. And we also want to learn from you. We want to hear what your experience has been and if there's anything that we could learn. So at this point, I know we're ending about 4 minutes early, and we did build 15 minutes in on the back end for any feedback. So I am going to stop my screen share and my recording.